Good afternoon, everyone. My name is Preeti Gopinath. I'm part of the BAUP organising committee for the monthly webinars, and welcome once again for our next webinar on mimics of prostate cancer. That'll be delivered by Professor Rajal Shah and Professor Gladell Paner. Just as a reminder, so this is our organising committee. And these are the forthcoming webinars that will be coming up in the next year. So as you can see, some great topics coming up. And it gives my pleasure to introduce a very eminent faculty we've got today, Professor Rajal Shah, who's Professor of Pathology in Texas and President of the Genitourinary Pathology Society. Author of many publications and textbooks, and real pleasure to have Prof. Shah here with us. And we have also Professor Gladell Paner, who's Professor of Pathology at University of Chicago, and is also eminent author and contributor to international guidelines. Just as a reminder from housekeeping, that if you could put your questions to the speakers in the Q&A box, please, and please refrain from putting questions in the chat because the speakers will be monitoring the Q&A specifically. If you're following us on the YouTube live stream, you can put questions on there, and we will transfer them over to the speakers to view. I will. Sorry. I'm just going to do a quick poll to hopefully you can see that. Just let us know what your designation is. Okay, I'll just share that. Thank you. And also let us know where, oh, sorry. Sorry, yeah, there we go. So also let us know whereabouts you practice in the world. Great, so mix of places we've got today, so that's great. So thank you very much for that, and without further ado, I will hand over to Rajal to start. Thank you.
Can you see my screen?
Yes.
Yes. Thank you, Preeti, for kind introduction. Good morning, good afternoon, or good evening, depending on which part of the world you are joining from. It's a great pleasure and honor for us to participate in this webinar. And I would also like to thank organizers for this invitation. So this will be the outline of this webinar. And again, this is meant to be a very interactive one. So I think please feel free to stop us in between, I think, if there is any specific question. First, I will give a little bit overview on this particular topic. I will give a little bit about the significance of this topic for the benefit of trainees. I will also talk about how you can develop a more effective approach to this prostate specimen evaluation. I will talk a little bit about pattern-based recognition of benign mimics. Histological features, when present, could argue against the cancer diagnosis and can be very helpful to identify a benign process. And then finally, most of our time will be based on case-based discussion. And Dr. Paner has selected 5 cases, and I have selected 4 cases. So that will be our main presentation. So as you know that particularly in Western world with PSA screening, the prostate cancer incidence is quite high. With this high incidence, we are significantly detecting low grade, typically grade group 1 prostate cancer. Some of them are indolent cancers. So there is clearly a push towards less aggressive treatment approach for these low grade cancers because there is a concern of overdiagnosis and over treatment. So I think in these days, when you make a diagnosis of grade group 1 prostate cancer, it would be very unusual not to offer patient an active surveillance or conservative treatment option. So I think with all that, I think awareness of benign mimics is quite important to avoid false positive diagnosis and unwarranted treatment. So a effective way you can develop a prostate biopsy evaluation is a three-step approach, and I cannot emphasize enough on the importance of low power examination. So I typically examine prostate specimens at 4x magnification, looking for subtle architectural and cytoplasmic differences. And always try to keep benign glands as your reference point for comparison. Am I dealing with a proliferation which has a different cytoplasmic qualities than the adjacent benign glands, whether there is any architectural atypia or not? And if you think there is architectural and cytological changes or cytoplasmic differences, then your next step is to look carefully for cytological atypia at high power. And the last step before we make a cancer diagnosis is to rule out benign conditions that may cause architectural and cytological atypia, which is the focus of this webinar today. So there are a variety of benign conditions that are known to give both architectural as well as cytological atypia. And as you can see from the list, this benign mimics include some normal anatomical structures, inflammation, reactive conditions, as well as some pathological processes, pathophysiological processes. So an effective approach to recognize and work up these mimics is to use a pattern-based approach. And if you use that pattern-based approach, you can classify these benign mimics in essentially 3 patterns. The most common pattern is going to be mimic of well-formed or mimic of Gleason pattern 3, which is well-formed small to mid-sized discrete glands. And as you can see here, variety of benign conditions fall into this particular low-grade cancer mimic. Then there are some proliferations which are large with some cribriforming architecture, which can mimic intraductal carcinoma, atypical intraductal proliferation, which are suspicious for intraductal carcinoma, and sometimes in extreme situation can mimic the cribriform cancer as well as other high-grade process. And then the last architecture is when you have a poorly formed or fused glands, nest, single cells, which is a mimic of a high-grade cancer. And I think particularly it is very, very important that you don't overdiagnose this type of high-grade processes. So again, low power examination is going to be critical, and that importance I can not emphasize enough, and we will show you that throughout this presentation, the importance of that. So now with that basic kind of guideline, you can use some of the morphological features when present, arguing against the cancer diagnosis. Essentially, these are not specific features, but they can be helpful to suggest that you are dealing with a benign process. So at low power, when you see a quite lobulated or circumscribed process, like an example like this, and as you would agree with me that this is a nice example of a Cowper's gland, you see a very tightly circumscribed process showing biomorphic population of these small acinar glands lined by mucinous epithelium with some ducts like in between. So most of the benign mimics will have this type of lobulated architecture. Sometimes you may see little haphazard or patch-like or disorganized architecture. But paying attention to low power architecture is a very important first step for your impression. When you have glands in question, when you are worried about certain processes, then try to recognize adjacent benign gland. And as you can see here, this is a nice benign gland for your reference point. And when I compare this proliferation with adjacent benign gland, I don't see any cytoplasmic or cytological differences between them, suggesting to me that I'm dealing with a more benign process, and particularly partial atrophy and adenosis, also known as adenomatous hyperplasia, are classic examples showing this type of particular feature. And we will show you some cases as well. In this proliferation, you see very dark looking glands, raising concern for cancer. You also see prominent nucleoli. So if you jump at high power, I mean, this is going to look scary. But I think why they look dark, because they don't have any cytoplasm, giving you an impression that this is clearly a benign process. When nuclei occupy full cell height without any cytoplasm, then you have to think about benign process. And typically complete atrophy, which is an example shown here, also known as post-atrophic hyperplasia, basal cell hyperplasia, all this would have this type of feature classically. Here is a beautiful example of BPH-like stroma, which is characterized by this cellular spindly stroma. And I find this stroma very, very helpful when I see atypical architecture or any atypical looking glands and have surrounded by this type of very cellular BPH stroma. The first thing that comes to mind is that could I be dealing with any of this type of benign process, basal cell hyperplasia, adenosis, sclerosing adenosis, or sometimes just like more florid BPH type of process. When you see random type of cytological atypia, what I mean by that is that within a well-formed gland, some nuclei appear bizarre and some nuclei appear absolutely benign. Like you can see here that these are some of the bizarre nuclei, while some nuclei look very benign. So when you have this type of random cytological atypia in a well-formed glands, you typically would think about seminal vesicle, ejaculatory duct epithelium, radiation atypia, which will have atrophic glands with a similar type of cytological feature. And here is a beautiful example of seminal vesicle and ejaculatory duct epithelium. Now, also you need to know about the pitfalls. When you use immunohistochemistry, you must know what are the pitfalls. Use internal control as your guideline. So particularly basal cell immunohistochemistry may show fragmented or patchy positivity in small proportion of cases. It may entirely lack basal cells. Classic example are partial atrophy, adenosis, sclerosing adenosis. I have seen examples where adenosis and sclerosing adenosis may show just rare basal cells and the whole focus may look negative. Racemase, our cancer marker in the PIN4 stain, can be overexpressed in many mimics, high-grade PIN, nephrogenic adenoma, adenosis. So I think very important to know the limitations of these markers. We talked about some of these architectural and cytological atypia. Prominent nucleoli are very common with post-atrophic hyperplasia, basal cell hyperplasia, and inflammation. So you have to analyze a particular feature in the context of the whole process, not just isolated. Because if you look at features isolated, you are likely going to go to a wrong direction. Then finally, I think when you are dealing with something unusual, think about that what type of specimen you are dealing with. Am I dealing with a more transition zone representation or peripheral zone representation? Because we know that certain processes like sclerosing adenosis, clear cell cribriform hyperplasia, basal cell hyperplasia, they are likely going to be encountered in transition zone. And in contrast, like if you are worried about intraductal carcinoma or a cancer, it's more likely going to be in the peripheral zone of the prostate. I mean, of course, these are not absolute, but I think this type of basic kind of understanding, I think, will help you reinforce your diagnosis. So with that, I now ask Dr. Gladell to share his thesis.
Thank you, Rajal. And I will take this opportunity to thank the organizers. And it's an honor and a pleasure to present here in the BAUP webinar. And to add some points, Rajal did a good, very good introduction there. And if I may add, we talked about the use of immunohistochemistry when we're dealing with these challenging cases. But if you follow what Rajal, the approach that Rajal detailed, in some instances, we may not even have to use immunohistochemistry in those settings. So what I'm gonna do is I'm gonna deal with 5 groups of mimics, and within this five compartments, I'm gonna present 6 cases, and I'm gonna start with this. Will be my case 1, and this case, this is a prostate biopsy from an adult male or elderly male with elevated BSA. And as you can see in the screen, as highlighted by Rajal, it's very important to start first with the architecture of this histology. And as you can see here, the glands in some areas, they're kind of have regular lumen, and you can see some luminal features there. You have some amorphous secretions and crystalloids there. These are features that usually, but not specifically associated with cancer. However, in some areas, that you can see the glands is a little bit more rigid, exhibit sharpness of the lumina. On closer inspection, you can see that the nuclei, they they are bland. They don't really have this prominent nucleoli. And so overall, the architecture, they are small, exhibit some crowding, exhibit some bit of rigidity. And although the nuclear features is not that striking, I would say. And then I did stain on this case just to show, and you can see some fragmented staining. This is pin 4, and you can see some fragmented staining. There's basal cell markers in some of these atypical glands. However, in some part there, some of the glands completely does not show any staining in the basal aspect of the gland. And I wanna go over, we have some poll questions, but I would pause here for discussions. If any of our panelists have some questions or some points to point out about this case, or any comment is welcome.
Should I launch the poll?
Yes, if you can comment, Rajal, feel free. So we have a poll, please put your answers. So the question is, what is your diagnosis? Is it benign, suspicious, or carcinoma? I think we only have choices there, benign or carcinoma. So the vast majority answered benign, 96%. And it's pretty clear based on that staining that although there were glands, this particular focus here have absent staining, the rest of the glands have this patchy staining with basal cells, meaning that they have basal cells. And if you look at these glands overall, those glands without basal cell staining look morphologically similar to these glands with basal cells. So are these the same glands? If we're gonna call those glands without basal cell staining as cancer, then we might have to call those with basal cell staining as cancer as well, which is not. Now, the reason why I put this case up is because I think the reason why these glands are atypical is because there's a little bit of shrinkage here in the epithelium, some degree or part of the features of the spectrum of atrophy. And having said that, I'm going to use this case as my intro to talk about atrophy. So atrophy, glandular atrophy in the prostate, is broadly divided into 2. It can be diffuse, meaning that the whole area or even the zones or the entire gland can be diffusely atrophic, or the process can be just localized or focal. Now, if it is a focal atrophy, then it can mimic, that's kind of more, can mimic a carcinoma process. And then different types of atrophy. There's the simple atrophy, but overall, atrophy has this architecture, and usually the glands have this I use the word angles to describe this, and I added a drawing there just to emphasize that, when you look at the glands, you see in some of the edges, you see this point like this. It's not kind of a perfectly circle or kind of a regular contour of the side. And then on low power, they look basophilic, obviously because of the less cytoplasm and the dominance of the nuclear features. It makes them blue on low power magnification. Now, the basal cells are present and sometimes they can be prominent. And if you do stains, you can be prominent like this. This is high molecular weight keratin. But in some instances, the basal cells can be patchy, as shown in this example, and the example also that we shown earlier of a partial atrophy. So sometimes the basal cells can be fragmented, as you can see here with the brown staining, with PIN4 immunostain. However, in most instances, you really don't need stains to identify atrophy. If you just examine and remember the different features of atrophy, like for example, in this case, to the left of the screen, there's a carcinoma focus there, as shown on that high power magnification as well. And to the right, comparing it with atrophy, and you can see the differences both architecturally and also cytomorphologically. So you can see that the glands are darker because of the less cytoplasm and the dominance of the nucleus. And importantly, if you compare it to the carcinoma, there is no the nuclear features of cancer, like prominent nucleoli, multiple nucleoli, is not identified or present in atrophy. Sometimes there can be prominent nucleoli in the spectrum of atrophy, but this is like kind of a mildly distinct nucleolus. It can happen, but not that's big, prominent, large nucleolus or nucleoli that you would see in some carcinoma. Now, our topic is about benign mimics. And when we talked about a particular or specific benign mimic, then we should know or remember what particular carcinoma will look like that benign mimic. So in short, what will be the counterpart of that mimic? For example, if we talk about small benign gland proliferation, then obviously the cancer mimic will be a Gleason pattern 3 cancer gland. So in short, we have to identify its kind of partner mimic in the malignant side. And having said that, when we talked about atrophy, we have to keep in mind that there's also this atrophic cancer. Now, don't worry about this. This is not a common entity. You will not see this regularly, but you have to keep this entity in the back of your mind. This is rare, but it can happen. Now, atrophic cancer architecturally will resemble benign atrophy, as you can see on this example. This particular focus of cancer, the glands, as you can see, are angulated or stellate, and it has this bluish tincture on low power magnification because of the dominance of the nuclei. However, unlike atrophy, even at this magnification, you can see or appreciate the nuclear features of cancer. Other features that may help on scanning magnification, the luminal features, in cancers, usually it's associated with crystalloids, amorphous secretions, or mucin. And when you pick that up, at least spend some time going on high power just to make sure that that atrophy on low power magnification is potentially not an atrophic cancer. Another image of atrophic cancer, just to put some emphasis on the nuclear features of malignancy that you can see, despite this cancer having the architecture that resembles a benign atrophic glands. This is an interesting case that Morales shared with me. And if you can see here to the left side, there's atrophic cancer, and to the right, there's benign atrophic glands. And you can see that architecturally, they somewhat resemble each other. However, if you do basal cell markers, the basal cells obviously are staining in the benign atrophic glands. However, if you go back to the left, you can see the difference in the nuclei is striking for that reason. Now, I'll gonna cover the different types of atrophy. We talked about simple atrophy, and there's also this so-called post-atrophic hyperplasia, although personally I prefer to call this as lobular atrophy. So this is basically just an atrophy of the entire ductal acinus component. And usually they are multifocal because multiple acinar complex can be involved. And so the idea here or the theory here is that there's this glandular atrophy and then followed by proliferation of these atrophic glands. And usually they have an associated larger ducts, you can see in this case. And interestingly, in this situation of atrophy, the stroma have this kind of somewhat kind of a degenerative appearance, something like a kind of looks like an elastosis in the skin, and which is an interesting feature. But however, overall, the glands, the acinus, would have the features of atrophy. And really, this has no clinical significance, except that, of course, not to that this will be a mimic of prostate cancer. Now, a problematic within the spectrum of atrophy, the problematic atrophy is the partial atrophy. And this is actually the most common reason for consultation with a question of, is it benign or malignant? Now, the word partial, meaning that it's not yet completely atrophic. So what is partial atrophy? So unlike the simple atrophy that I've shown earlier, partial atrophy has a little bit more rounder nuclei, and then the cells, they are kind of cuboidal, they have a more ample cytoplasm, and then architecturally, they have this stellate appearance. And you can still appreciate the lobular configuration of this unit. Now, in some areas though, like here in this part, you can see some of the glands exhibiting rigidity. It no longer has this stellate appearance, and it's kind of becoming more atypical. One thing also about partial atrophy, if you examine the surroundings, sometimes, as you can see in this case here, if you look at this gland here, within that lobule, you can see some glands that are already completely atrophic, or meaning that they already have flattened epithelium, and then the nuclei of that cell is already going into the lumina. Now, this is a partial atrophy wherein it exhibits some rigidity. And as I mentioned earlier, sometimes atrophy may have this mildly distinct nucleolus, and it can create some problems, especially in this case here. So there's rigidity, there's prominent nucleoli, so then it becomes a problem. And this morphologic atypicality is confounded by the immunistical staining with basal cell markers. And the reason for that is because partial atrophy will have patchy basal cell staining. As you can see in this case, some of the glands, they have no staining with the basal cell markers. This is P63, and some of the glands in the background there, you can see that they have this kind of fragmented, patchy staining. So having described this other, within the spectrum of atrophy, I'm going to move over to the second case. So this is case 2.
Can I make a quick comment, Gladell?
Please,
I think very nice presentation, and I think very beautiful case. I think one thing that I would caution to the audience is that basically, if you are morphologically very comfortable making a diagnosis of partial atrophy or atrophy, then don't use immunohistochemistry, because there are good chances that you may be misguided because of the pitfalls that we discuss. So I think knowing your kind of pitfalls is important, but same time, I think just use of immunohistochemistry for curiosity is not a very good idea, because that can potentially lead you. And then the other point I would make is that you don't want to make a diagnosis of atrophic cancer in a very few small glands. I mean, you need to, in certain situation, know your kind of threshold and limits. And I think in that situation, if you think that there is definitely atypical features, but then you just call suspicious or atypical. But I think I would not make particularly some of these unusual cancer morphologies in a very few glands. I would not make that diagnosis.
Thank you, Rajal. That's a good point. Regarding atrophic cancer, as I said earlier, this is a rare entity. So this is not something that you would see, but at least keep it in the back of your mind. And I like the point that you mentioned about the use of or overuse of immunohistochemistry. We have to keep in mind this. Some experts would use the word immunoconfusion for that, so it kind of confound the problem. So now let's get over to case number 2. So again, this is a prostate biopsy for a patient with elevated PSA. To the left of the screen, you can see that the glands are kind of widely, there's a more stroma in between the glands, kind of space there. And you can see in this cluster here, there's kind of angulated glands, and then there's kind of smaller glands scattered around it. And here it's kind of a closer inspection. You can see that gland that I described, it has this irregular lumina, kind of looks basophilic, and then next around it, you can see some glands with some luminal content. You see some amorphous secretions there, probably mucin there, and then maybe perhaps that's crystalloid there. In other areas, you can see some glands that are angulated, basophilic, and then you can see some glands with a little bit more cytoplasm, some luminal content there as well. And here you can see some glands, again, angulated, basophilic. Some glands would have a little bit modest or still scant cytoplasm, and then some have mucinous material. And I'm gonna do the poll again for this case. So what is your diagnosis for this case? And Rajal, if you can run the poll. Right, so right now we're at the 50-50 level. All right, so 51% thinks it's benign. So we have no consensus here, and 49% says carcinoma. So obviously this case further wanted some discussion. So going back to the morphology, so one feature here that is striking, at least from my in my personal opinion, is that this mucin, this amorphous secretions, and I think there's some probably hints there of crystalloids. By the way, this luminal content, I kind of always state this to my residents. This is important. Although they are not specific, if you see all these three all together in a single focus, there's a high likelihood that you're looking at a carcinoma. Now, I didn't put here a closer inspection, but in some areas here, unfortunately, it's not obvious here that there's prominent nucleoli on some of these glands. And the obvious reason why this is difficult is because, and I will show the stain for this case. And there you go. So some of this focus, and this is the reason why I've shown this case, is that there's an intermingling here. Those, if I can go back, these glands with a little bit more cytoplasm turned out to be carcinoma. So it's kind of the problem here, and the challenge that I have with this case is that there's some areas of atrophy, and there's also cancer that exhibits some features of atrophy. Although morphologically, in some areas, I'm confident I can call this as cancer. Now, the challenge is in some areas, I'm having problems. And as we know now, we're not having a diagnosis of cancer is not enough. We also have to quantify the extent of cancer. So we really have to go through glands to and then kind of report the extent of the cancer in percent or in millimeters. So we need really to have this overall understanding of the extent of the cancer in the core. I will welcome any comment if there's any from the panelists.
Yeah, no, I think very nice case. And I think again emphasizes you have to look at all I think different aspects like architectural. You can see beautiful infiltrative type architecture. Of course, there is a beautiful staining, good number of glands, and then I think Gladell already showed some of the cytological features. And I think in comparison to benign glands, the cytoplasm here is a lot more amphiphilic. So I think this is clearly a quite abnormal process with a good number of glands, good support from immunohistochemistry, and I think you can make a more confident call for grade group 1 cancer.
Thank you, Rajal. And not to scare everyone, so we talked about partial atrophy. There will be some instances wherein the cancer itself would look somewhat like partial atrophy. As you can see in this example, so if you look at in this core, at the tip of this core, there's a proliferation here of small glands, and the glands have some of them have irregular lumen, some of them shows irregular lumen there, and some of them have rigidity. On closer inspection, however, unlike partial atrophy, here you can appreciate the prominent nucleolus. And this is the kind of cases that to me it's justified to do pin 4, and I did pin 4 in this case, and this it turned out to be carcinoma. Going back to the spectrum of atrophy, there's another type of rare kind of atrophy called sclerosing atrophy. So this particular atrophy is associated with some stromal changes. In the background, you see that the stroma is fibrotic. And because of this fibrosis, it kind of compresses the glands, and the glands, which already have the features of atrophy, becomes more compressed. And in this process, it's called sclerosing atrophy, the glands are more angulated. And because of this compression, in fact, some of these compressed atrophic glands may have this pseudo-infiltrative features. And this is a nice case that Murali shared with me. If you look at some of these glands, because of the sclerotic stroma, the glands are compressed, and you can see they're highlighted by a basal cell marker. And you can see there that the compressed glands have this kind of infiltrative look, almost mimicking like a high-grade cancer, a Gleason pattern 5 with the single filing of the cells there. Although on closer inspection, you will not be seeing here the high-grade nuclear features of cancer. Further expanding to the spectrum of atrophy, this is usually not a diagnostic issue, this atrophy with cyst formation. So this is basically the glands are atrophic, but they are cystically dilated. And because of that dilatation, there's relatively less amount of stroma in between these dilated glands. And if you look at the lining on closer inspection, it has the usual features of atrophy: flattened nuclei, less size cytoplasm, and the nuclei is reaching the lumina. And the reason why I brought up this particular benign entity is that because it can closely resembles this microcystic adenocarcinoma. Again, not to scare everyone, this is a variant, but this is a rare entity, but something that we have to keep in mind when we're encountering this cystic atrophy, benign cystic atrophy. So microcystic adenoma on low power magnification has this kind of certain hints or features, particularly the luminal features. As you can see here, it has some amorphous, this eosinophilic material in the lumina, and sometimes you may see some crystalloids with it. So these two are luminal features are associated, although not specific, with cancer. So something that would warrant closer inspection. Now, the good thing is that, at least for the cases that have been reported of microcystic adenocarcinoma, they are usually occurs in association with the conventional acinar adenocarcinoma, as you can appreciate there in the periphery of this large gland. So how do we call this as cancer? So on high power magnification, you can appreciate the nuclear features of cancer. And you can see the prominent nucleoli there. So unlike atrophy, you don't see these features. And also there's a little bit in some areas, there's atrophy, but in some areas there's also some amount, some cytoplasm, modest to, in fact, it's more ample in some areas. And also there's this feature that the nuclei tends to align closer to the basement membrane. So that's microcystic adenocarcinoma. Again, it's rare, but something that you have to keep in mind when you are seeing some areas of cyst formation in the prostate. Now, I'm gonna move to a different topic now. And with that, I'm gonna go over to case number 3. And this, I find this case very, very challenging. So let's discuss this case. So this is a prostate biopsy of an adult male for elevated PSA. And to the left, you can see here the core. The rest of the core, so there's 12 cores in this case. This is only in one core. And in this core, especially at the edge of this core, you can see some glandular proliferation. And in the tip, you can see also some, that there's a lining there at the tip of this core where the core ends. Now, underneath that, there's this proliferation, mainly in tubular patterns. You can appreciate on low power magnification, there's mucin. And again, here, there's some tubular proliferation. And there's some calcifications there. On closer inspection, you can see that the tubules, they are atypical. They have this prominent, in some areas, they have this distinct chromocenters, but not really like big, although randomly, maybe there is, you can argue. And in some, there's a little bit of complexity of the tubular structures. And in some areas, there's mucin. So it's clearly these tubules, they are atypical. And on staining with pin 4, you can see the strong staining of the glands. You can appreciate there the red. So this is pin 4, so red is amacar, and brown is high molecular weight keratin. And you can appreciate, I would leave you guys to interpret the staining on your own. So now let's go over with the full question, and then we can discuss this case. So right now we have no consensus, but still some are still voting, and I will stop here. So we have 56% saying it's carcinoma. So there's more in favor of carcinoma, and 44% says this is benign. And I understand, there's no consensus here. This is a very, very challenging case, and this turned out to be actually a benign process. This is a nephrogenic adenoma. I'm gonna go back to this case to discuss the specifics of this case, but before that, I'm gonna discuss first what is nephrogenic adenoma. Okay, and then we're gonna go back to that specific case to discuss why it was. So actually, that was a case that was misdiagnosed, and then on review, we called it as benign. So nephrogenic adenoma, some would call this as metaplasia. And the classic nephrogenic adenoma, as we know, it has this biphasic growth. It has a papillary growth, as you can see here, somewhat papillary. Although in some areas, you can also flatten the surface. And this papillary is right there at the surface. And then underneath, it has a tubular component as well, tubular proliferation. That's why we use the word biphasic growth to describe nephrogenic adenoma. And the cells lining the tubules and the surface component, the flat or the papillary component, are the same. Usually they are can be flattened, cuboidal, or characteristically they are hobnailed, as you can see here. Now, some of these tubules, they may have some secretions. Some of them may have this prominent basement membrane-like material, kind of look like blood vessels. Some of them will have kind of more like a kind of a distinct tubule formation. Some may have well-formed glands, well-formed tubules formation. Some may have a poorly formed tubules. And then this may happen. Nephrogenic adenoma, as we know, can happen in any part of the urinary tract, right? So from the pelvis all the way down to the urethra. Now, nephrogenic adenoma can occur right there in the surface in the prostatic urethra, and then this process. So underneath, right, there's a tubular component. This tubular proliferation can extend downward and approaches, if not, can be close into the proximity of the prostate. And then right there, because it's a tubular formation exhibiting some atypia, it becomes a differential diagnosis for prostate carcinoma. And this is what happened in this case. So first, let's talk about the staining, because that staining of the that case that I showed has a striking red staining there. So first of all, nephrogenic adenoma, the word nephro is there. So basically, phenotypically, it's like the renal epithelial tubular cells, right? So it should be staining with PAX8. Now, in terms of PIN4 staining, it's a little bit challenging because nephrogenic adenoma can mimic prostate cancer because of the AMACAR overexpression. So it expresses AMACAR so that it will pick up the red staining, just like prostate cancer. Nephrogenic adenoma, however, unlike prostate carcinoma, would also stain with high molecular weight keratin. It can be patchy, it can be extensive, but so it will pick up also that brown staining. As you can see here, so it has brown, it has red staining the same area. And that high molecular weight staining is not like in prostate cancer where you have this, or in benign prostatic glands where you have it in the basal side of the gland. Here, it's the same cell that would pick up the brown staining. Just to mention that this entity will be negative for NKX 3.1, which is a good stain to distinguish this from prostate cancer. PSA have some issues, but you can also use PSA, but you have to be careful in interpreting PSA. But I would rather recommend NKX 3.1. Now, going back to PIN4 and going back to that case, so here it can easily be misinterpreted as this overexpression of AMACAR. What happened here is this basal cell staining. There's some hints of brown. In fact, we can use the word reddish brown in some areas. The problem here is that the red is so strong that it overwhelms and it basically covers the brown staining. And now it can be misinterpreted as just a red staining. Now pay attention here to the surface. The surface also actually have the same staining in some of this like kind of reddish brown. And actually, if you look at it morphologically, it also has the same types of cells that is what we're seeing in this tubular proliferation. So this is the surface. This is the urethra, right here, the surface of the urethra with some changes of nephrogenic adenoma there in the surface, and then this tubular proliferation went down there, and this is captured. This process is captured in prostate biopsy, and in this instance, usually, so it can be seen right there at the tip. Now, since this is in the prostatic urethra, I just want to emphasize that this is not a common scenario to happen. It just that happened here, and in this case, it's actually fatal. So it can happen, but usually we see this process more in a transurethral resection specimen. So it's uncommon in biopsy, but keep this in mind. It's usually right there at the tip. It has a surface component, and then it has this tubular proliferation. Now, going further to nephrogenic adenoma, some of this histology. So we show that it has some tubular formations. These tubules can also be poorly formed. Rarely, it may even show fused glands. And rarely, we have to be aware that it also may show some complexities. These tubules or glands can be crowded. It may even show some fusion, and this fusion can be dense, that it may already look like kind of what somewhat like solid. And if you can imagine, if it happens to be overcalled as cancer, right? And this will be graded as a high-grade cancer. So keep this in mind, this process, nephrogenic adenoma, it's a close mimic of cancer because both morphologically and immunohistochemically, there's mimicry with carcinoma. So keep this entity in mind. And again, nephrogenic adenoma, although it's not it's not common to see in a biopsy. It's more common in a transurethral resection specimen. It can happen, and when it happens in a biopsy, it has this really striking resemblance to prostate carcinoma. So I'm gonna move now to the third category. And with this, I'm gonna start with a case. So in this case, this is not a biopsy. This is a transurethral resection for a urinary obstruction. And you can see this here with the histology. So there's a glandular proliferation, small glands, and then you can see it's vaguely lobular. And in the central aspect of this glandular proliferation, the glands are bigger. And on the side and the periphery, the glands are smaller, and some of the glands kind of goes a little bit off there, away from this kind of circumscribed or circumscription, vague circumscription. And some of the glands have some concretions there, or some amorphous secretions maybe, and then some, and distinctively we can identify that there are some crystalloids. On closer inspection, the cells really, they don't have this prominent nucleoli, although in some maybe there's some mildly visible nucleoli, and going to the edge, that's kind of have this kind of smaller glands that are kind of percolating away or kind of infiltrating away from the main group of glands. And I did IHC on this case. I did pin-4 staining. And in the central aspect, you can see here some patchy basal cells. There's some degree of picking up the red staining of Amacar. But as you can see in some areas right there, especially at the periphery, there's loss of basal cell marker staining. So I like to share this to everybody, what's your thought about this case? If you can give us your thoughts about this case. Do you think this is benign? This is a carcinoma?
There is no suspicious category for them.
Yeah, we're forcing everybody to commit. All right, I think we're getting a consensus here. Yeah, so yeah, I can end it here. So yeah, so 78% thinks that this is benign, and 22% thinks that it's cancer. So majority thinks that this is oops, there you go. Majority thinks that this is cancer. So this is benign. So 78% think that this is benign, and we agree with that opinion. So basically, this is benign. And this is kind of related to the very, very first case that I've shown, when it comes to staining, right? So when staining the basal cells, so when you look at the whole group of cells of glands that look similar, you have to treat them all as a part of the same. So imagine if that's a cancer, we're looking at basically at the same clone, right? So if some of them have basal cells, the rest of the glands which looks the same will not be cancer as well. And that's basically the one principle of interpreting basal cell marker immunostaining. And this process basically is adenosis. And I'm gonna go over to discuss adenosis, unless someone in the panel have opinion about that case to point out. Okay, so yeah, so I'll continue. So adenosis, some would call it a typical adenomatous hyperplasia, but this terminology already fell on the side because of the word adenomatous there. And we know now that this is not really strongly, if has no association or not a precursor of carcinoma. And as we know now, historically, some of these may even have been called the Gleason pattern 1 or Gleason pattern 2. So adenosis, usually they're more common in or seen in the transition zone of the prostate, and they exhibit their circumscription with the larger glands in the central aspect, smaller glands in the periphery. And then the stroma, since they are like hyperplastic process, may have a hyperplastic type stroma in between these glands. And one features of this, as shown in that example of the case, is that some of these glands may have crystalloids. and as well as some luminal secretions, features that associated with cancer, and kind of raises the possibility of cancer, especially if we have this on a biopsy. So as I said, some of the glands are bigger in the middle, and then in the periphery they are smaller. And morphologically, it's really kind of, we have some difficulties identifying the basal cells. And as you can see here, also in the stroma has this kind of some a little bit more spindle. So it's kind of, have this flavor of a hyperplasia stroma, although I don't find this feature consistent. I see some, I saw adenosis, which doesn't have this, clearly this kind of a hyperplastic type stroma. Now, if you do immunohistochemistry here, just like some of this within the spectrum of atrophy, some adenosis also have this patchy basal cell staining, as you can see here. And this obviously, this patchy basal cell staining can be a problem. We talked about this immunoconfusion, right? So it's kind of, we already have some problem morphologically. And then this type of basal cell staining, this patchiness, this fragmented, can be an issue. And I would show two examples here, and this is courtesy of Morali. He gave me this very nice case of adenosis. And if you look at here, this is small gland proliferation. So we're probably looking at the periphery of the adenosis. That part potentially was sampled. Although here you can appreciate the stroma, right? It's kind of have this little bit more like a hyperplastic appearing. And then here, this focus of basal cell proliferation. So with this, right, it kind of, at least this one kind of helps us that, hey, this is not cancer, right? This is not cancer. The other glands that look similar, hey, of course, those I would not call this as cancer as well. I would pause because of this basal cell proliferation. But it is remarkable, as only one gland have this basal cells, and it's kind of, the basal cells is kind of putting an exclamation point there that they are proliferating or hyperplastic at one part. And there's another example here. This is, again, an adenosis, the smaller gland areas, and showing that the high molecular weight keratin staining here is fragmented patch, and only a few of the glands are picking up basal cells. So beware of this type of staining. In terms of interpretation, so some practical tips here. When we interpret basal cells, examine all the atypical glands within a focus. The whole focus should have no basal cell markers to lean towards cancer. And of course, when we do, say in biopsy, right, we sometimes, when we have multiple sections on one slide, so make sure also to examine those underlying sections. Make sure that there's really complete or zero staining of basal cell markers. And but again, it can be a fitful because some parts of the adenosis may really have complete absence of basal cells, depending on what part is sampled. And in those certain scenarios, you have to.
If I can make one point, sorry to interrupt you. But I think, this is a beautiful case, and I think, Gladell has already emphasized this enough, but I think one point that you can do is that compare the, on the right side, on the immunohistochemistry side, compare the glands which are staining and compare the glands which are not staining. And you don't see any difference in cytoplasmic or cytological characteristics between them. So I think that is always a good point to keep in mind, that in that setting, you can call this benign process. Murli also had some.
Amrali, please go ahead.
Yeah, I was just going to make a point. So this was, the way we do our immuno, we do the immuno on the same level as the HNA. And in other organs, it really doesn't matter. But in prostate biopsies, that's extremely useful, because as you can see in these pictures, you can identify gland by gland. So you can, because when it comes to interpreting prostate immunohistochemistry, you have to see the morphology of the gland that is positive and the morphology of the gland that is negative. So I think that, for us at least, it works much better than using immuno on a deeper level. So if you request immuno on a deeper level, I would strongly recommend you also ask for a corresponding HNA on the immunostained level.
That's a very good point, Morali. Thank you. So going further, so additional images of adenosis. So this is a biopsy, and we talked about adenosis in a TURP or in a radical prostatectomy. We can appreciate the circumscription, the lobularity of or the circumscription of this process. If you have it in a biopsy, you can imagine here that this is in fact a circumscribed nodule, and then you see this sharp transition at the edge. So you have this proliferation on one side, and then you abruptly stop, and then you have this stroma. So you can appreciate the end of the process there. But see, this is, we talked about the problems, the histomorphologically here, you can see some of the glands have this rigidity, and some of them have, in fact, some luminal content associated with cancer. And you look at the staining here with basal cells. So again, this patchiness. And some of these are not exhibited in the stain of the basal cell marker. But if you go over gland to gland, as Rajal nicely pointed out, these glands without and with staining, they look the same. So you cannot call the whole thing as cancer, basically, because of that. Now, we talked about the stroma in adenosis. There's, of course, in some instances, the stroma will be like hyperplasia-like, and I just want to show it here. See the stroma in the background, and this is really very helpful. This is kind of easier to identify. And on biopsy, this is, of course, how it would look like. So it still has the features of adenosis, small gland proliferation intermingling with larger glands, and some of the small glands have this crystalloids, amorphous secretions. And then in the background, of course, you can see this kind of stromal changes, which is kind of associated with hyperplastic process. And adenosis, since it's more common in the transition zone, it's usually sampled or seen in a TURP specimen, as you can see in this case. Again, you can see the circumscription there. And with high molecular weight keratin, again, you can see this patchiness of the basal cell marker staining of this malignant mimic. Now, extending within the spectrum of hyperplasia. So this is not really a problem when we see benign hyperplasia. Benign hyperplasia, we can easily diagnose it or see it. We usually see it in TURP, right, for urinary obstructions. And hyperplasia, basically, there's nodular and epithelial proliferation. This epithelial, the glands have this kind of, because of the proliferation, it has this luminal unfoldings of the hyperplastic lining. But if you look closely at the cells, you can appreciate, in fact, the basal cells are relatively much more identifiable in benign hyperplasia, and the cells itself, the acinar cells, they don't exhibit some atypia. And the reason why I just want to put benign hyperplasia there is, again, a pitfall here. I don't want to scare anyone, but again, this is a rare type of cancer, but with something that we have to keep in mind. A close mimic of benign hyperplasia, it's pseudo-hyperplastic adenocarcinoma. And architecturally, this will resemble hyperplasia. So, so for a start, right, we always have to look at low power view. We have our assessment on the architecture of the process. So here, architecturally, they resemble, but something that we have to keep in mind, and something that we might have to examine on high power magnification. So what are those features that would trigger us for closer inspection? So we talked about the changes that we see in microcystic carcinoma earlier. So actually, pseudohyperplastic has some overlap with microcystic carcinoma in terms of the features. Like, for example, it may also show some of these amorphous secretions. So that's one soft sign there that you can consider. And then sometimes it's not seen here, but you may see some crystalloids. I think there's one there maybe. And one thing is that, as I mentioned earlier, in the microcystic carcinoma, the nuclei of the cells are kind of more like oriented towards the basement membrane. So something like that. And then if you look at high power magnification, then you'll appreciate the nuclear features, which is more like that of cancer. So enlarged nuclei and prominent nucleoli. And most of the pseudo-hyperplastic adenocarcinoma that's been reported are usually associated with concomitant, or there's a concomitant conventional adenocarcinoma, as you can see here. So, so something like that, and examine the periphery. And if you see a conventional adenocarcinoma, that's really very, very helpful. All right, so now we're gonna move to the.
I think before Gladell, you move to case 5, there are some questions. If you can I think one of them you just addressed. One question is, can you please show? So there is an anonymous attendee who has questioned, can you please show normal transitional zone histology if possible? And I think you already showed that, I think.
The normal transition zone, right? So let me see here. So normal transition zone. So the transition zone. So we have three zones, right? We have the peripheral zone, the transition zone, and then the central zone. The transition zone is different from those two zones. So in the setting, just go directly to what we see in terms of prostate cancer. We usually see the prostate in elderly male. And it happens that BPH is very common. BPH is a process localized, usually almost exclusively in the transition zone. So when we see the transition zone, even if the patient has no symptom of BPH, we may see some nodules there. So it's kind of have this nodular configuration. And then the epithelium, they are not as small as you would see in the peripheral zone, or not as slit-like or elongated. And then the stroma is not as dense as the one that you would see in the central zone. But a feature that I usually see there is that you can see some of this big nodularity. Some of them are kind of trying to form BPH. BPH is so common, although not all the patients will have symptoms, but the histologic process itself is common. And it happens that most of the patients with prostate cancer are also those patients, those cohort who will exhibit these histologic features of BPH. So it's kind of a clue that you are in the transition zone.
Another question is, what was the thought process behind the case of nephrogenic adenoma? It seemed quite like carcinoma. Was it radiologically benign? And the question is raised by Muhammad Umair Khan.
Yeah, so actually, so that case came out as I said, so only that case was only that core was showed that process. The patient came with elevated PSA, biopsy, and then the patient was sent to us, and it's actually for review. So here we reviewed the cases before the patient have surgery, and yeah, so we made a call based only on that specific biopsy. No, we don't have anything radiologic or anything. We just basically made it our call, and we're confident. And we have to stop. Actually, the patient was supposed to have a radical prostatectomy for that.
Yeah, I think one point that I would make is that biopsy was urethral biopsy, right? Is that correct?
No, it's a standard biopsy.
Prostate biopsy?
Yeah, it's a standard, it's a regular biopsy, systematic biopsy. And sometimes, this biopsy, right, it kind of misdirected or probably goes there into the urethra. That's why it's at the edge of the biopsy. It stops, right? Because after the urethra, it's a space. So that will be, the end of the core. That's why.
I mean, you see some urethral lining that is a little bit clue there.
No, so the
I
line.
think it's a very tough case, very tough case.
It's a very, very, very tough case. It's a very, very tough case. Yeah.
Another question is immunohistochemistry mandatory to diagnose prostate cancer, especially for pattern 3?
Rajab, maybe you can answer that.
Yeah, I mean, absolutely not. I mean, most of your cancer, you really don't need immunohistochemistry when they have sufficient architectural and cytological details. You would use immunohistochemistry when focus is relatively small, or maybe in a situation like this pseudo-hyperplastic cancer or atrophic cancer, when the focus has a little bit subtle type of changes. And I think you really want to, in particularly era of immunoactive surveillance type of treatment, you really want to have a high threshold to call small focus of cancer. If you are in doubt, let it go as a suspicious or atypical and ask for a repeat biopsy. That is more prudent, I think, in this particular one. So I think you need to, and I think, I mean, this to some extent it's a experience, and if you have doubts, show to an expert or show to your colleagues in a consensus conference. All of those things have shown to improve the accuracy of your diagnosis. Murli?
Morally, you're muted.
You are muted. Murli, you are muted.
Yeah, also consider the clinical scenario. I mean, how useful, that important it is in that case. So for example, if you got a patient who's on active surveillance, then don't worry too much whether this is suspicious or pattern 3 cancer. It doesn't matter. The patient's already got a diagnosis of cancer. They only want to know whether he's got higher grade cancer. Similarly, if you've got an obvious cancer in one core, then don't worry too much about that tiny focus on the other core, because that's only going to decide the number of cores positive. You already got a diagnosis of cancer. So also think about the clinical utility.
Thanks,
Yeah,
Murali.
I think those are good points.
Very, very good points. I love that point about active surveillance versus a new patient. And actually, so in my practice, I actually have that habit. So what I tell my resident is to kind of divide the cases, the prostate biopsy pile, into active surveillance, and then where is the new patient? Because for the active surveillance, we just basically, we know that those are already cancer patients. We just screen for progression, increase in stage, and increase in grade, and increase in extent. And so, as Murali nicely pointed out, for those atypical glands, I really don't spend so much time there, because as you know, it's not going to change the management. This patient will still be put on active surveillance, even if we call that small focus as a small focus of cancer. And just, I would ask the rest of the panel, so maybe a good follow-up question is, how often do we order stains in our prostate biopsy cases? So from my experience, probably 5% of my cases. So I don't know, you, Rajal, and you, Murali.
Yeah, I mean, perhaps less than around 5%. I think definitely not more than 5%. And I think, you definitely don't want to use immunohistochemistry for curiosity. It is more when you are really worried about it, to confirm your morphological impression. That is the number one important point to keep in mind.
Murali, you're muted.
I agree with you guys, okay, that not to overuse immuno. But on the other hand, a diagnosis of GG1, if you got the slightest doubt, do the immuno. So, because a diagnosis of 1 millimeter 3+3, the patient could opt for radical prostatectomy. Yes, he may be recommended surveillance, but he could opt for prostatectomy. So compared to all the other specialities where the sarcoma guys would use 20 markers to subtype their malignancy, it's entirely reasonable to use 2 markers in a case if you got even the slightest doubt before you diagnose it as cancer.
Yeah, absolutely.
Absolutely. Yeah. Just for the granularity for my comments. So, you also have to know, right? We have to know, and we know that the cutoff when it becomes the patient will be eligible or suboptimal for active surveillance. If that small atypical focus is going to change it, we're going to the 4th, 5th course or 6th course with some atypical focus. Maybe it's time to work them up already, because they're going to extend the volume of the involvement of the course for that particular case. So in those cases,
those are the questions. So I think you can move to question number 5.
All right, so now we'll move to the 4th category, and now we're gonna be dealing with the more complex architecture now. And to go over to the discussion, I'm gonna share this case. So this time, this is a radical prostatectomy of an intermediate risk prostate cancer. The patient had a GG2 prostate cancer, underwent radical prostatectomy. And in one of the sections, it shows this proliferative process. So you can see there on low power magnification, some of the glands are more complex, bigger. And clearly you can appreciate even on low power magnification that this glands has what we call as the cribriform proliferation, characterized by these luminal proliferations of cells forming these bridges interconnecting these cellular proliferations and creating these multiple spaces within the lumina. In this central area, though, it's kind of a little bit, it's a lot larger actually than the rest. And zooming in into that, so again, you can see this kind of a cribriforming of the process, and you can actually appreciate here, you can see some basal cells, but you can see the proliferation there, and you can see some concretions as well. On closer inspection, though, the nuclei is not really that atypical. There may be some discrete chromocenters that if not maybe there, but it's not really like strikingly prominent. In some areas, like in the periphery, there's this kind of usual cribriform. Again, you can see actually the basal cells here is prominent, and you can see the stroma there is have this kind of a hyperplastic stroma flavor. And again, another area there of showing this proliferation. So I like to share this for your opinion. Please answer the poll. So is this benign, or is this a carcinoma process? So we have a majority opinion here of 81% thinks that this is benign, and that's obviously, you know, this is a correct diagnosis, and this is a carcinoma. I'm sorry, a benign process. And so what is this process? Get stuck. There you go. So this is a clear cell cribriform hyperplasia, and this is one form of hyperplasia wherein it has this distinct features of a cribriform architectures with cells that have this clear to lightly eosinophilic cytoplasm. And as I pointed out earlier, and you saw as well, that this process, the nuclear features, they have gland, they have the nuclear activity. Now, one thing about this, and we pointed out already, is that the basal cells are usually prominent. I think this is something to do about the clearing of the cytoplasm of the proliferating cells. Is kind of create this contrast because the basal cells doesn't have the clear cytoplasm. So it kind of create this contrast. And we talked about the stroma, kind of have this hyperplastic stroma. Now, going into the cribriform, you know, and cribriform really is coming, you know, it's a very interesting topic in prostate cancer pathology. So the cribriform group, you know, we can divide. There's the different entities that is within the cribriform. You can see there some are benign, some are intermediate, or some are benign, and some are frankly cancer, and some are in between. So, but for the purpose of this discussion, I'm gonna talk only, or put my emphasis only on this benign mimics. And we talked about clear cell cribriform hyperplasia, and Rajal will talk later about the basal cell hyperplasia. And I'm gonna talk a little bit more about the central zone gland. So central zone glands, we talked a little bit about transition zone earlier. So transition zone, that's the area around the urethra, and I use that as a landmark, you know, in my radical prostatectomy. So urethra is around it, is usually the transition zone. Now, central zone, the landmark that I use is the ejaculatory duct. So the area surrounding the ejaculatory duct is the central zone. So it's in the posterior upper part of the prostate. And in the central zone, the glands are relatively bigger. They're more complex. They have this papillary enfoldings in the gland. And that's why, you know, when it has a biopsy that is capturing the base of the prostate, it may sample the central zone. So beware that this histology in the central zone can mimic pin architecturally. So you have to keep that in mind. Now, usually they are larger with these papillary enfoldings, but uncommonly they may also have some bridging, and it can form somewhat kind of cribriforming within the large glands. And the cells, though, if you look closely, of course, they don't exhibit the atypia that you would see in these other cribriform processes, especially the neoplastic ones. And if you're lucky, actually, you can see some pigments, also some lipofuscin pigments, the same pigments that you would see in the nearby ejaculatory duct. And again, just to emphasize, the stroma there is much denser than the rest of the prostate. The way I imagine the way the stroma is dense, because it kind of goes into the bladder neck, so it kind of becoming more muscle there, and then it becomes this the musculature, the smooth musculature of the bladder wall. So it's kind of have this within the closer to that transition. Now, just to go in passing, just to mention, you know, so the differential diagnosis obviously is the invasive cribriform gland. So architecturally, it resembles clear cell cribriform hyperplasia. But of course, you know, cribriform carcinoma, they have the features of carcinoma. So nuclear, just the nuclear, you know, they have this atypicality that you would not see in a clear cell cribriform hyperplasia. Now, to go further in the invasive cribriform gland. I'm not going to discuss it, but I just like to mention it that we have now definitions of cribriform glands, and the way the reason why we put it out is obviously to increase the reproducibility in the diagnosis of cribriform gland, because now it's important. We have to report the presence of cribriform gland, and I use this definition. One is by Rajal, and then another one by from ISOP. And these two definitions are basically, if you read them, they are the same. But so I use this for us, my criteria for invasive cribriform glands. Now, we talked about this high-grade cribriform. Another high-grade cribriform is intraductal carcinoma, and the difference between invasive cribriform and intraductal is the presence of basal cells in intraductal carcinoma. In most instances, intraductal carcinoma, you see the basal cells. You don't need immunohistochemistry. And just like cribriform, you have to report the presence of intraductal carcinoma in your report. But in some instances, though, in intraductal carcinoma, the basal cells can be patchy. So distinguishing it from invasive cribriform carcinoma may be challenging. But again, distinguishing this from clear cell cribriform hyperplasia, in addition to the difference in the cellular tincture, unlike the rest of the benign processes, the nuclear feature here will be high grade. And there's I just want to show this. So we use, for intraductal carcinoma, there are different criteria, but we usually follow the criteria by Go and Epstein's. And if something fell short here, and Rajal, I know we'll discuss this later in more depth. So we use the word atypical intraductal proliferation. And this is something new entity that we already need to diagnose, because this has clinical implication. The patient may have an underlying or undersampled intraductal carcinoma. All right, so this will be the last segment for my part of cases. So this is case 6. So this is a biopsy, again, adult male patient came with an elevated PSA, and it shows this proliferation. So you can see that in some areas you have this kind of foaminess of this cell proliferating. Some of them are aggregating, some of them are kind of have this kind of infiltrating pattern. Some of them are kind of like trabecular there, and some are maybe like kind of in single cells going on high power. You can see the foaminess of the cytoplasm, and then I think there's some kind of a brownish coloration also of the cytoplasm, you can see there. And zooming in further, looking at the nuclei really don't have the nuclear features, I would say, that we can we usually see commonly in cancer. So we would like to do a poll to ask your opinion on this case. So the question is this benign or is this cancer? So the majority, we have 88% thinks that this is a benign process, which we agree. So this is this process is called acenthoma, basically in the prostate. And this is basically just histiocytic proliferation in the prostate. And we can confirm this with CD68 stain. As you can see there, the cells are staining with CD68, which is a histiocytic marker. One marker is suffice in this case. Some may do additional stain like keratin, for example, which will be keratin negative. Be very careful though with the use of PSA here. There are reports that, these are histiocytes, right? So they can non-specifically pick up PSA here. So there are reports that they can pick up PSA. So just be cautious about using PSA here. Now, in this case, they have this brownish coloration, maybe from old hemorrhage. Maybe this is related to the prior procedure. But in this other example right here, this doesn't have that brownish discoloration. And here it's a little bit more challenging than the case that I've shown, because in this case, the background prostate also shows some partially atrophic glands, which has also some foaminess or kind of clearing in the cytoplasm. So it kind of blends with this histiocytic proliferation. And this particular case was also confirmed with CD68. Now, the differential diagnosis for xanthomatous inflammation will be a foamy gland carcinoma, especially if that foamy gland has this kind of infiltrative appearance. Some are single cells, and then now you can see this histiocytic kind of similarity with the histiocytic process, especially if you don't form those glands. So how do we make a distinction? Well, first of all, for foamy gland carcinoma, one feature of foamy gland carcinoma is that it doesn't usually have this enlarged nuclei and prominent nucleoli that you would see in conventional adenocarcinoma. They have this kind of pinpoint kind of nuclei and that's why it's kind of mimic this xanthoma process. But how to distinguish it morphologically? So, foamy gland adenocarcinoma, it's an epithelial process, it's a carcinoma. So if you look closely to the clusters of the gland, you can appreciate the cellular boundaries. You can see there, and unlike in a xanthoma, which basically forms, if they aggregate, they're forming a syncytium, right? So there's no boundary in between the cells, or no prominent boundary within the cells. And of course, if you go around the foamy gland, then you will see some structural features there that resembles a gland, which a xanthoma obviously cannot replicate or can form. Now, just a little bit of digression here. When we talked about foamy gland carcinoma, they can also have this well-formed pattern. So they have this foaminess in the cytoplasm. And again, as I pointed out earlier, they have this pinpoint nuclei, which has no prominent nucleoli. And because of that, then it can resemble the Cowper's gland. So Rajal showed earlier a very good example of a Cowper's gland. So more about Cowper's gland. So usually this is sampled right there in the apex because it's right there at the apical side of the prostate, right there at the sphincter, the muscular sphincter. And because it's in the sphincter, we usually see skeletal muscle associated with this structure. And in terms of the histology of the foamy gland, so basically they look like a minor salivary gland. So the cytoplasm has this kind of mucinous appearance. And if you look at the individual glands, you may actually see glands that are different like this. These are the intercalated ducts. So finding these intercalated ducts is also helpful from the morphological aspect. Usually you don't need to stain this, but if you want to stain this in a high molecular weight, it would be positive here. Be careful though with PSA here, it can be positive in Cowper's gland. Going back to xanthoma, so another differential, and Rajal will discuss this in detail, this radiation treated prostate cancer. So, especially if it is markedly treated, so the cells, they undergo regressions, there's some separations of the cells, and then, they're not forming this good tubular structure. So they kind of look like basically histiocytic because of the foaminess of the cytoplasm. So something that we have to keep in mind, and of course, important is the history of knowing the history of radiation. And finally, just to go over, we really don't have a problem with this, identifying chronic inflammation in the prostate biopsy. But of course, there will be instances, there will be artifacts, some problems, in the morphology. The morphology is not optimal, and then we kind of have some problems with this chronic inflammation. So the most common inflammation, or the more common pathologic inflammation that we see in prostate is this chronic non-specific granulomatous prostatitis, and typically it has this polymorphous infiltrate. So polymorphous, different types of cells. There's dominance of lymphocytes and plasma cells admixed with neutrophils, and sometimes you may see eosinophils as well, and macrophages. And a differential here will be, of course, a small cell carcinoma, but cytologically, it looks different, right? You see the molding there, you see some crushing cells. But again, as I pointed out earlier, it can be a problem once the morphology is not optimal, as you can see in this core right there. And just to keep in mind for inflammation, of course, we have to think of the high-grade cancer that leads in pattern 5, and then this hormone-treated carcinoma, wherein the cells goes into basically regressions and the shrinkage and atrophy of the treated cancer, and they will look like chronic inflammation. But if you look around, in these two processes, you may see some glandular formations, more kind of cohesive cells. So, it would basically something that would not be possible with just chronic inflammation. And this is the last slide for my part, and this is just a reiteration with what Rachel nicely showed earlier. So we have to keep in mind that the mimic, and we have to group the mimics, knowing what the corresponding carcinoma pattern that they resemble. And if we can group them, so I can group them into two. So basically based on the patterns, essentially the Gleason patterns, and based also on the patterns of the variants. And most of the mimics would fall into the well-formed gland, mimicking basically Gleason pattern tree. But obviously, some others will resemble the carcinoma with more complex architecture in Gleason pattern 4 and Gleason pattern 5. And with that, I will hand this over to Rajal.
Thank you very much, Gladell. I think we do have some question, but I personally favor that for benefit of time now, let me finish my 5 cases, and then we can go over the questions. So this is my case, 87-year-old male with a history of prostate cancer, status post-radiation with rising PSA. His latest PSA is 6.16 nanogram per ml, and MP-MRI was also performed. It revealed no convincing focal lesions worrisome for prostate cancer. No focal lesions worrisome for prostate cancer, although diffuse abnormal signals within prostate may obscure smaller lesions. So I have some images. This is a low power view, and I will not, I will make my description more after I think I take your poll, but you can see that we have clearly somewhat disorganized glands. They look kind of more dark. And I think at higher magnification, there is definitely significant cytological ATPI. You can also see prominent nucleoli in many of them. Here is another look at a closer magnification. So I think now I would like to open the poll. Gladell, can you open up the poll? I think I will close the poll now. So, I mean, we have quite a range here, about 4% called normal tissue, 52% benign proliferation. There are a couple of for high-grade pain, 10 participants have atypical intraductal proliferation, suspicious for intraductal carcinoma. There is also grade group 1 prostate cancer. It's about 13 participants, and then some for 3+4, 8 people. And so quite a range. So, I mean, you can see that this type of, I think, prostate biopsies does kind of create a lot of diagnostic difficulties. So I think, again, I think what I would like to emphasize in my cases is that I will focus on low power, and then we'll also focus on some of the high power details. So I think at low power, what you see in this case is that there is a relatively paucity of glands, means you have less number of glands, more stroma. Stroma also appears a little bit hyalinized and sclerotic type. And also notice that these glands are rather atrophic. You have very scant cytoplasm within them. And we talked about that when you see the random type of cytological atypia, which is, I think, nicely appreciated here, that you have some nuclei which appear bizarre, almost like pleomorphic, while some nuclei appear extremely small, like a completely benign looking indolent type of epignotic nuclei. So there is quite a variation in the size and shape of the nuclei. Other thing to also appreciate that there is a degenerative type atypia. I mean, you can see almost smudgy chromatin pattern. You see some cytoplasmic vacuoles within these glands. And here again, appreciate this very atrophic nature of these glands with random cytological atypia, degenerative hypochromatic type of pattern. So all these features, when you see, should always raise a question that has patient received a treatment? Now, I did provide that in the history, but many times you may not receive that history. So unless you morphologically appreciate these changes, you may go into wrong direction. So I think appreciating this treatment effect is very, very, very important. And I think, again, I cannot emphasize enough on this, some of these features that we discussed. If you are in doubt, I think good news is that I think particularly in radiation atypia, I always find that basal cell staining is usually pretty intact and will light up in these small glands. So the diagnosis for this case is benign prostatic tissue showing radiation therapy effect. So this post-radiotherapy biopsy typically are performed 30 to 36 months after radiation treatment. But keep in mind that radiation changes can persist for many, many years. So I think it is not unusual to see even after second, third year to see still some evidence of radiation-induced cytological changes as well as atrophic nature of the glands. Other setting where the biopsy might be done, it could be due to rising PSA with PSA nadir. What I mean by PSA nadir is that PSA dropped to certain level to a lowest point and then started rising. So that is always a concerning sign. Or patient has an MRI lesion. All of this setting could lead to a post-radiotherapy biopsy. And in this setting, you could be dealing with any of these three situations: radiation atypia in benign glands mimicking cancer, like the example that I showed you in my case. Another scenario is residual cancer showing treatment effect. And we will discuss what are those treatment effects. But typically, you have glands which have started breaking down. So typically, this treated cancer looks worse than what it is actually. So because of that worse appearance, because of the glandular breakdown, because of the nuclei becoming pycnotic and almost shrunken type of lymphocyte-like nuclei, sometimes in very advanced cases, they can look like lymphocytes, or they can look like pattern 5 type of cancer if you don't pay attention. So that is why we typically do not grade when you see a good histological evidence of radiation treatment effect. And then the third setting is where you have a radio recurrent prostate cancer. Patient responded to radiation, but then some of the clones, resistant clones started coming back, or there is a new clones that started coming back. And these cancers don't have any treatment effect. And those cancers, very important to grade them. And I think I will address our paper that we published on this one. To me, this is the cancer that you do not want to miss, because this is the cancer which is very harmful to the patient and typically has aggressive outcomes. So typically post-radiation biopsy findings and PSA nadir are independent predictors of outcome and subsequent recurrence-free survival. And as I mentioned, new or resistant tumor clones without significant treatment effects more likely to demonstrate poor outcomes. And these are the one very important to grade it, while this particularly showing treatment effect you do not want to grade. So we published in Modern Pathology a series of salvage radical prostatectomy cases. These were the patients who were treated with radiation and then end up failing it, and then also received subsequently salvage radical prostatectomy as a treatment. And we demonstrated that in this particular setting, These tumors are often rich in cribriform morphologies, which is, we know that it's an adverse pathological feature. You can here see some evidence of radiation damage, but both intraductal and invasive cribriform pattern were very frequent. So I think this is very important to grade and also mention some of these particular morphologies. And here is the side-by-side comparison of post-radiation atypia, which is our case. While in the cancer showing therapy effect, you see more haphazard proliferation, random type of glands. You can see relatively abundant cytoplasm rather than atrophic glands. Ballooning of the cytoplasm is another very helpful feature. Sometimes you have missing extravasation and glands are breaking down, becoming pycnotic. So you can see that nuclei are almost pycnotic. You don't see good nucleoli in this one. So pycnotic, degenerative type of nuclei, very important clue. Ballooning of the cytoplasm, cytoplasmic vacuolization, mucin extravasation, all those features you must think about radiation atypia. I think Gladell want to raise some point. Gladell, go ahead.
Oh, I just like to emphasize that's a very, very good point that you make, Rajal, about grading in the post-radiation setting. Because since I was harassed, there's common knowledge that after radiation you cannot grade the prostate cancer. So that's a good point that you make. And to add further to that, as you mentioned, I just like to emphasize. So after radiation, these patients are usually not followed by biopsy. The patients are followed by TSA level. And if there's a biopsy at the post-radiation setting, so there is an indication, there's a clinical suspicion why that patient has biopsied. So keep an eye on those, keep an eye for the recurrent cancer or even a de novo, as Rajal pointed out, a new clone of cancer. And in those settings, you can actually render a grade for that particular cancer.
Yeah, no, I think that's very important points. So I think again, here you don't see any treatment effect. This is like a good radio recurrent cancer, and this type of cancer you must grade. Also mention about cribriform intraductal morphology, because this is going to be not a good news for this particular type of patients. So with that, let's move to second case. 70-year-old male presented with
Rajal, I think Murali has.
Murali also had a point. So I think maybe I can
just very brief, Rajul, just to be aware that when it comes to radiotherapy, brachytherapy effects last much longer than external beam radiotherapy.
Yes,
So you can get even after several, even after 10 years, you can get brachytherapy, post-brachytherapy radiotherapy changes in both the benign glands.
Yeah. So this is a 70-year-old male who presented with significant long-standing urinary tract symptoms and elevated PSA of 8 nanogram per ml. MRI revealed a Pyrex 4 lesion involving the anterior prostate, and then patient underwent transurethral resection of prostate. So this is the low power view and very crowded, very cellular process that you are seeing here. So this is the low power view. And also I think many of these glands almost impart a cribriforming appearance. This is a little bit closer. And again, you can see the cribriform type of glands. And this is the high power appearance, where you can see some nuclear features, nuclear details. Also appreciate the stroma. So I would now ask for Paul to run. It's about 30 seconds and I will stop the poll. So again, I think we have a range of diagnosis, no clear consensus. About 40% thought adenoid cystic carcinoma. That's a very important thought, and I admire, I think, you considering that possibility. 1% thought urothelial carcinoma, 2 thought grade group 5 prostate cancer, 1 thought grade group 2, 2 thought grade group 1, about 47% thought benign proliferation, 3 thought normal tissue, and then some for atypical intraductal proliferation. So quite a range here. And I think this is, again, I think somewhat unusual case. But my diagnosis for this case is basal cell hyperplasia. You can also refer to this type of process as a basal cell adenoma, particularly when you see in a transition zone, making a clear-cut tumor type of proliferation, like the case I shared with you. So this particular process is commonly associated with BPH, atrophy, and in the setting of androgen therapy. This type of exuberant proliferation, in my opinion, is more common with benign prostatic hyperplasia. But again, as I told you earlier, we know that certain processes are more common in transition zone, and this particular, because basal cell hyperplasia to some extent is a kind of a benign prostatic enlargement. So you are likely going to see this in a TURP and radical prostatectomy or simple prostatectomy type of specimens, compared to needle biopsy. Rarely you can see that in needle biopsy as well, and I will share with you some examples. And this is a very versatile lesion. It can give you small gland or nest type of architecture. Sometimes it can give you large glands or pseudocribriform glands, like the case example that I shared with you. So I think what are important clues? Again, I cannot emphasize enough the low power view, and I think you can see here that this process abruptly stops right there. You can almost draw a beautiful circle around this proliferation, and that tells me that I'm likely dealing with a contained benign type of proliferation. If this was an adenoid cystic carcinoma, I would expect some degree of infiltrative architecture or some degree of perineural invasion. Just cytology is not enough to make this adenoid cystic carcinoma, even though it has that cribriforming and highly nice type of stroma. At high power, you often see this type of nuclear stratification and nuclei occupying full cell height. And remember, we discussed this particular feature. When you have that nuclei occupy full cell height, think about first a benign process. Nuclei are more ovoid, coffee bean-like. You may even see some grooves within them because they have like that coffee bean type of architecture. It also has been described as a pack of cigar with very limited cytoplasm in between. But some of them can have more cytoplasm. So there are 2 types of basal cell processes, one which is more complete and the other one which is more incomplete. Ours is more incomplete type of basal cell hyperplasia, where you may see some more cytoplasm. Calcifications are also very common in this kind of intracytoplasmic hyaline globules are also common. Also important to keep in mind that prominent nucleoli are very, very common with this process. So if you jump at high power, nuclei may look scary, but I think they have a little bit more degenerative and coffee bean type of appearance. So those are the important features to appreciate. This is an example in a biopsy, and shows you a little bit gland, small gland or nest-like appearance. But look, pay attention to this stroma, beautiful BPH-like stroma, nuclear stratification, ovoid coffee bean-like nuclei with almost nuclei occupying full cell height. So I think these are the features that tells me that I'm dealing with a benign process. Here is this is relatively more challenging, where you have a little bit more haphazard proliferation. But again, I mean, here no cytoplasm, nuclei occupying full cell height, almost kind of coffee bean type of nuclei, and beautiful pack of cigar-like appearance, ovoid appearance with some prominent nucleoli. But this is the type of case where you definitely want to do basal cell markers. And I think, again, I would emphasize that if you do basal cell marker in a situation like this, use both P63 and 34 beta E12, because sometimes if you use only P63, you may go into wrong direction. Here is a little bit more high power experience, which is showing beautiful prominent nucleoli. So Hostler and colleagues, this is from Jonathan Epstein group a long time back. I think they published a series of atypical features in basal cell hyperplasia and described many of these type of atypical features. Now, some of them, in my opinion, they are intrinsic to this process, and you may find variably like prominent nucleoli, mucin, calcifications, altered stroma with increased cellularity, which we know that it's a BPH-like stroma, not stromal desmoplasia. So these features don't bother me. It actually helps me making the more informed diagnosis. But if I truly see infiltrative pattern or perineural invasion, I would pause, I would stop before making a diagnosis of basal cell hyperplasia. And I would start thinking about some of the other things as well. So here is a beautiful example where you see this kind of very basal cell hyperplasia like atrophic glands. But I think one thing you notice is that there is a clearly infiltrative appearance. You have glands, they are kind of percolating in between and around the benign, obvious benign glands. Here is a more better example. And at higher magnification, you see beautiful cytological atypia within these glands. So I think, again, I did both P63 and 34 beta E12, and this one was diffuse P63 positive and 34 beta E12 negative. So this is one of the rare example of P63 positive prostate adenocarcinoma. And we can talk more about that at some other point, but this is a very unusual type of prostate cancer. Here, these glands looks poorly formed. They look almost like streaming like cords, but they tend to do pretty well in most of the outcome studies that have been published on this particular entity. So keep in mind about this when you see this type of infiltrative atrophic basal cell hyperplasia like process. Think about P63 positive prostate adenocarcinoma, because this one not only can potentially mimic like benign, but can also give you a very aggressive diagnosis, which is not the case in most of the time with P63 positive. These are most of the time considered grade group 1 prostate cancer, or at the most some grade group 2 features. Here is another case where you see this kind of very similar basaloid or atrophic looking glands, but obvious infiltrative process. You also see this hyalinization, little bit elastotic type of stroma. Glands look little bit darker than the typical one. But when I see this type of infiltrative process, then I would definitely think about adenoid cystic, basal cell carcinoma, P63 positive, prostate adenocarcinoma, and sometimes atypical basal cell hyperplasia, but I would not allow this type of infiltrative process for a benign condition like basal cell hyperplasia. Here is another example of adenoid cystic basal cell carcinoma. So this is an example of adenoid cystic basal cell carcinoma. I had also done NFIB fusion, which was negative, but overall very infiltrative process. And this one was P63 positive, 34 beta E12 positive, PSA was negative, and very clearly infiltrative process. So I think we made the diagnosis of adenoid cystic basal cell carcinoma. Here is another example. This was seen in a needle biopsy, and you can see that there is some fat cells. So this is clearly infiltrative process, but this one has a more prominent adenoid cystic type of morphology, similar to what we see sometime in salivary gland tumors, adenoid cystic carcinoma. So there is quite a resemblance with salivary gland tumors. You also see this type of hyaline type of material, which is quite common with adenoid cystic carcinoma of salivary gland tumors. So here is one paper where you see this differential diagnosis of three relatively close entities. So first of all, of course, you will pay heavy attention to the morphology. We show that P63 positive and basal cell carcinoma would be clearly infiltrative, while basal cell hyperplasia, it will be more circumscribed process. You can use Ki67 in this instance, particularly because basal cell carcinoma often will have a high Ki67 greater than 20%. BCL2 is also usually overexpressed in basal cell adenoid cystic basal cell carcinoma, and P63 positive prostate adenocarcinoma is negative for high molecular cytokeratin and positive for ESA, while these other two entities are positive both for high molecular cytokeratin and P63, but negative for PSA. So these are some of the very helpful features that can help you make a more confident diagnosis. Those who have more additional resources, you can also do MIB NFIB fusion, but they are positive only about 40% of adenoid cystic basal cell carcinoma. So negative FISH does not rule out this positive, this particular entity. And keep in mind that these type of fusions are more prevalent with the adenoid cystic morphology, while the case that I shared with you earlier had a more nested and cord-like growth pattern. So I think with that, I would move to third case. A 65-year-old male with an elevated PSA of 8 nanogram per ml underwent a standard extended biopsy, and biopsy from the left base is shown. So this is relatively like medium magnification, where you see these crowded and relatively complex looking glands. You also see a little bit beginning of a loose cribriform type of proliferation, but we still don't have really true cribriform proliferation. Here is another look of this particular biopsy where you start seeing a more loose cribriform type of proliferation, and a little bit more closer. And this is another view of this case where I think it looks quite a little bit almost looking like dance. So I would open the poll. Okay, again, I think we have quite a range here, but range is at least limited. So about 40% thought this is benign proliferation, 10% normal tissue, some high-grade pain, and about 30% atypical intraductal proliferation suspicious for intraductal carcinoma, and 4% intraductal carcinoma. One thought 3+3, and one thought urothelial carcinoma. So I think like this is like the majority range is very reasonable, that your thinking is quite kind of correct. And I will share with you my thought on this particular case. So my diagnosis for this is central zone gland. So I definitely think that this is a benign proliferation. So central zone glands is a posteriorly situated cone-like structure with base projecting toward the bladder and apex is towards the well-mountain area. And it is primarily considered a mimicker of high-grade pain. So very commonly, when it is proliferative, you may mimic with high-grade pain, but I have also seen good number of examples where it mimics like atypical intraductal proliferation, like the case that I showed you, that some of the glands certainly started looking little worrisome, but in the whole context, I don't think there is sufficient evidence to call that atypical intraductal proliferation. And if you are in doubt, you can also do some additional stains as well. And I think this type of process is typically going to be biopsied in the base area. So my rule of thumb is that when I have a base biopsy, I have a high threshold to call something atypical or a high-grade pain. And I must rule out central zone glands before considering any of this type of atypical process. So one thing that I think very noticeable is that even though these glands looks proliferative, they have a very dense eosinophilic look to it. And I think I find that extremely helpful feature. I mean, I don't know about other panelists, but I think I find that a very, very helpful feature. I rely heavily on that. Other thing is I always kind of notice that the atypia may be there, but the atypia is more geared towards the basal cell type of atypia or basal zone atypia. They are not secretory cell type of atypia. And then you may see sometimes this type of arches and Roman bridges. So as I told you that, I mean, if I do side-by-side comparison with the high-grade pain, you will agree that, I mean, high-grade pain, you should have a more noticeable secretory cell type atypia with few prominent visible nucleoli at 20x magnification. And also notice the cytoplasmic differences. This is more amphophilic cytoplasm, like what we see in cancer typically, while this is more pale eosinophilic or densely eosinophilic type of cytoplasm. And the atypia here is more basal cell in nature. But in our case, I think we do have relatively more prominent loose cribriform proliferation. So pay attention to this type of loose cribriform areas where you have Roman bridges or Roman type of arches type of proliferation. Nuclei tend to proliferate in a streaming manner, or they are more parallel to the bridge, and that can be helpful feature. While if this is more a atypical intraductal proliferation or intraductal carcinoma, you would see more perpendicular arrangement of the nuclei. And I think, again, notice this dense eosinophilic nature of these glands. Here is, again, the cytoplasm is, and there is some prominent nucleoli, but they are primarily were seen on the basal aspect of these glands. So I think this is a somewhat tough case, but I think very important that before you consider atypical intraductal proliferation, intraductal carcinoma, try to ensure that you are not dealing with central zone glands. This process is also relatively isolated. While atypical intraductal proliferation, you are likely going to see much more glands, and it will be not usually just limited to one core. In this one, it was more limited. So I think Dr. Paner, I think, talked about atypical intraductal proliferation in his case. So atypical intraductal proliferation is a term that we use when the proliferation exceeds that of what you would allow for high-grade pain, but still does not fully reach the diagnostic threshold for intraductal carcinoma. For intraductal carcinoma, I would need a more dense architecture in which you have more cell proliferation than the luminal space, more 50% of the cell, greater than 50% of cells than the luminal space. Sometimes you may see solid architecture. If there is no dense or solid architecture, you would require homidonecrosis or marked pleomorphism. We don't have those type of features here yet. So I think this to me is suspicious for intraductal carcinoma. But in my practice, I don't allow making a diagnosis of cribriform high-grade pain in biopsy because I believe that you cannot exclude underlying intraductal carcinoma. So when you think that you have sufficient features to make a atypical diagnosis in a biopsy, and you have loose cribriform proliferation or some necrosis, focal necrosis, or atypia which exceeds kind of what you would allow for high-grade pain, think about atypical intraductal proliferation, because those patients often have unsampled intraductal carcinoma or more significant cancer in the radical prostatectomy. So patient would benefit from repeat biopsy. Now, Coming back to our case, I think you can see here the difference is the cytoplasmic eosinophilia, while here is more amphophilic cytoplasm. ATPI is much more pronounced, more luminal in nature, with a lot more cytoplasm between the nuclei. If you are in doubt, you can certainly try doing P10 and ERG, but keep in mind that they are not always going to be abnormal. If they are normal expression pattern, you cannot entirely exclude the possibility, and you will have to rely on morphology as your best guide. So I think that concludes the case 3. And again, we will take questions at end. Last case is a 60-year-old male with urinary obstruction and elevated PSA of 7 nanogram per ml. Patient underwent transurethral resection of prostate. And I have low power appearance where you see this very cellular process. Is another low power appearance. Very cellular looking process, particularly here in the middle. And also I think it looks like even cellular process around some glands. Here is more closer look to it. Another high power view. And this is the highest magnification. So I think now we can open the poll. Okay, so I will end the poll. So, I mean, at least we still don't have a consensus, but I think we have a majority which is considering benign proliferation. So that's really good. Some atypical intraductal proliferation, actually just 1%, 2 intraductal carcinoma, 4, 3+3. That's interesting. And then there is some for higher grade cancer, which makes sense, and 1% for urothelial carcinoma. So quite a range. So yeah, so the correct diagnosis for this case is sclerosing adenosis, which is a benign proliferation. And I cannot emphasize enough, I think, again, that a case like this really highlights the importance of a low power examination. Particularly, I think I always tell my residents that when you are examining breast and prostate, make your diagnosis at low power. Don't use high power to make your diagnosis. If you do that, you are frequently going to end up in a wrong direction. And I think at low power, it really shows nice circumscribed, very tightly circumscribed cellular process. You can also appreciate that sharp circumscription, which is abruptly ending here, and then you see completely relatively unaffected type of stroma. But if you jump at high power, this is a perfect example of a high-grade mimic, where you see fuse-looking glands, signet ring type of cells. But again, notice some of the other helpful features, very sclerotic pink stroma that can be helpful. And I think you can sometimes also see this kind of cellular spindly BPH-like stroma. So all those things putting together, I think, should always raise a concern about a benign process like sclerosing adenosis. And some facts about sclerosing adenosis, it's limited typically to transition zones. So I have still yet to encounter a good example of sclerosing adenosis in a needle biopsy. Very, very rare. Most likely you are going to see this in a TURP or radical prostatectomy type of specimen, typically seen as an incidental finding in TURP or radical prostatectomy specimen. So patient has a history like removed for a BPH type of process, and then suddenly you end up seeing this type of very cellular nodules. So a helpful clue is that when you have presence of one or multiple cellular nodules mimicking high-grade carcinoma in the transition zone, think about sclerosing adenosis. Basal cells can be very helpful, but they interestingly also undergo myoepithelial cell differentiation. So if you do smooth muscle actin or S100, they are going to be positive. And here is the P63 in my case, which beautifully highlights the basal cells. There may be some patchy staining, which I think we documented earlier on several examples that it is quite okay because the process looks all one. And this is S100 showing beautiful myoepithelial cell metaplasia in this case. So with that, I think we thank you for your attention. I think we will answer questions. So let's open up the question and answer. And I think we can, Murli, do we have time for that or?
Yeah, go ahead. So it's a
Yeah,
virtual
I
session.
think
So
we will be,
those
we will be,
of you who need to leave, you will get a link to view the recording, right? So if so you will have an opportunity to review this later. I'm sorry, I've lost electricity, which is why I'm sitting in the dark. But having said that, Rajal and Gladell have certainly enlightened me.
Thank you, Murali. Can I start the question? So I have a question, well, for myself and for the panelists, and this is an obvious question. So we talked about the spectrum of this benign mimics, and in fact, there are other mimics that we haven't even covered yet. So we really have a spectrum of these different mimics. Fundamentally, the clinical question will be: is it cancer or not? And the question is that when do we report? Do we have to mention? When do we have to mention these entities in our report, the specific entities? So to answer that question, first for myself is that I usually don't for some lesion, with the exception of if the biopsy is an MRI targeted biopsy, and I know that benign lesion may be responsible for that lesion that was picked up on MRI, especially those kind of related to hyperplasia. So I mentioned those in my report, and those are, I think, the only scenarios. And sometimes, if it is really obvious or something like that, I would put it in the report. But sometimes we got these questions from the clinicians, what it is, and then it kind of have this additional.
Yeah, I agree with you. I just will be very brief that I think if I have an MRI lesion, I would always try to mention some of these type of benign pathology, which could give false positive signal, false positive target. And I think sometime when we can name it, I think why not to name it? I think that's it. I think Murali, you are muted.
Muted, Murali.
All right. I'm going to leave my video off because I look very strange in the dark. I look strange anyway at best of times. But I think the most common situation where I mention these is actually when I'm reviewing a case and disagreeing with the outside pathologist. So if the outside pathologist has called it cancer, rather than just saying benign, if I think it is adenosis, I will put that in to explain why the other diagnosis was made. The other situation where I would mention it, where I think this is a difficult case, and somebody else might well be worried that it is cancer, and I think it is just adenosis. In those difficult cases, I might mention that I've seen this. It's not that I have missed this focus. I've seen this focus, and I'm interpreting it as adenosis.
Yeah. Okay. Can we go over some questions? I think for the benefit of time, I think we will be very brief. So first question is in Noshin has raised in core biopsy, the central dilated glands and peripheral smaller glands may not be clear. How to diagnose them? I think again, I don't know. I don't understand exactly the question very well. So anyone from the panel who has a better kind of last one?
I'm just guessing, but I'm not sure. But this is probably related to the diagnosis of this post-atrophic hyperplasia, or or maybe from the adenosis. But as the question highlighted, so it's not obviously it can be missed. This because in adenosis you have the nodularity, so this is better appreciated, the relationship of the spatial relationship of these large and small glands in a bigger sample, but will be at UR. So if it is clear, then you can, make this thing. But in some scenarios, obviously, you cannot tell where is the central part of that cluster.
The second question is, can Ki-67 help in differentiating clear cell cribriform hyperplasia from AIP or high-grade PIN? And I can answer that. I have never used Ki-67 to make that differential. In general, keep in mind that Ki-67 is going to be very low unless you are dealing with some kind of neuroendocrine carcinoma. Then that's a all different ball game. But I don't use that, and I would not consider that a reliable marker to help differentiating them. Next question is, what difference between hyperplastic stromolytes and cancer stromolyte? Gladell, I think you mentioned regarding sclerotic atrophy that might have raised this question.
Yeah, so hyperplastic is basically a proliferation of these spindle cells, bland spindle cells, and in cancer. So cancer generally, prostate cancer, they don't have, more commonly, they don't have this stromal response, right? But if there's a stromal response, then it's kind of that response is a desmoplasia, and desmoplasia is not cellular proliferation. It's more like a collagenous kind of matrix would have this bluish, grayish tincture to it. So it's different from the stroma that you will see in a hyperplastic, is composed of basically bland spindle cell proliferation. And again, this nodularity at the periphery that you would appreciate associated with.
Very good. Thank you. Next question is, NKX 3.1 will be negative in xanthoma. I believe.
Yeah, yes, it's negative.
It will be, because these are not prostatic cells. How often do you see clear cell CC in these biopsies? What is CC? Clear cell cribriform hyperplasia, right? In biopsies, most patients are CLL, SLLH. Again, I'm not sure what the CC means.
CLL probably is lymphoma, small lymphocytic lymphoma, and then CC is something about chronic inflammation, maybe. I'm not clear on the question. I'm sorry.
Okay. Could you please show the article again? I don't know which article. I think please feel free to reach us out, and I think we can try to address in email, or even I think if you on to Twitter, if you want to put something, we will try to definitely address your questions. But I think this one again, I'm not sure which article again. Is that something related to my radio recurrent prostate cancer that was published in 2022 Modern Pathology? And I think you can easily find that article. When do we grade the prostate carcinoma post-therapy? I think I covered that quite in detail. When you do not have any morphological evidence of treatment effect, even in the post-treatment setting, then you can grade the prostate cancer. Only time I don't grade is when I see the morphological evidence of treatment effect in the cancer. What are the features of residual malignancy after treatment? I think again, this is same question that is like quite overlapping. How to measure tumor in post-radiotherapy biopsy accurately? Again, I think this is as long as you recognize them as a cancer, you have to measure them from one end to another end, because in this setting, often the stroma can look a lot more, and you may have quite paucity of tumor. So I typically cover them from one end to another, unless there is they are just seen on the two ends of the biopsy. Then I think you may have to consider a different way. Residual cancer with treatment effect or recurrent cancer, when to grade? I think again we addressed this quite in detail, and hopefully it was clear to all of you. So I think that concludes, I think, all the questions. I think we thank you very much all for attending this session and staying with us all throughout. And we look forward connecting with you again. And thank you about organizers for this opportunity.
Yeah, I share the same. Thanks to the organizers and for giving me this opportunity. And before I drop out, I would like to make an announcement, important announcement talking about the timing. So today, there's a good news. So today, the new prostate cancer data sets from the ICCR, the International Collaboration of Cancer Reporting, will be officially released. So these data sets will include the radical prostatectomy, TURP, and then the biopsy. There's two, the biopsy for specimen level reporting, and then the biopsy case level reporting. So if you are using the ICCR data sets, go now to the website, iccr-cancer.org, and it's already there. And for the societies in your respective countries, if you are using the ICCR data sets, now it's the time to update your prostate cancer data sets. And again, thank you to the organizers for giving.
Thank you both. Thank you. It was excellent. And you covered literally everything from rare to common mimics. It was a pleasure. I'm sure everybody feels the same. Hope to see you again.
Thank you. Bye-bye.
Yeah, thanks both. Just an announcement, okay? So we don't have a webinar next in January because it clashes with the new year. So the next webinar will be in the beginning of February, where Selena and Dan Burney will be discussing a very important. It kind of follows on with this excellent presentation from Rajal and Gladell on the diagnosis of prostate cancer. So how do you deal with these problematic lesions? Rajal and Gladell, again, thanks very much for a very exhaustive talk, excellent talk. And as you can see, the majority of the attendees stayed on to the end because it was that good. Thank you.
Thank you so much.
Thank you.